Hi, good afternoon, everybody. I'm Mike Crosby, the Vice Chair for SNMMI Patient Advocacy and Advisory Board. I'm also the CEO and founder of Veterans Prostate Cancer Awareness. Our main mission is to educate and raise awareness among our 19 million vets that are in the United States. With that, we're here to talk about nuclear medicine and how it applies to prostate cancer and some of the very exciting stuff that's going on with prostate cancer. We've got two guest speakers, and actually three guest speakers. My partner, Jan Maneray of Cancer ABCs, is going to open up and give us the patient's view of what the heck is prostate cancer, or what is nuclear medicine in prostate cancer. And then we'll hear from Dr. Barangi from UCLA and Dr. Patel from Northwestern.
Thanks, Mike. Mike is a veteran advocate that in prostate cancer, I like to say we waited for him for a long time because we didn't have anyone for at least a decade, maybe 2 decades. So we're really grateful for what he does. My name is Jan Maneray. I'm the Executive Vice President of Cancer ABCs, but much more important than that, I was a wife when my husband was diagnosed with a PSA that was 7,096. He was 58 years old. Our son was 9. I was 45. I got involved very quickly, more than I ever thought I might or could. And before you know it, I was helping to engage in treatment choices and questions. And I was doing shared decision-making before I even knew what shared decision-making was. My husband lived for 13 years. One day, his medical oncologist gave me credit for that. So that is why I do what I do. So my goal, thank you, my goal is to pay forward what I learned accidentally that I didn't mean to. And in simple terms, better questions will get you better answers. I remember the day I stopped looking for answers and I started looking for questions instead. So I'm going to take that approach to what we do here and to helping with Q&A later. And I really want to meet people where they're at. And I really thought you guys were probably wondering what the heck is nuclear medicine and prostate cancer. So I thought I'd just hit that in my talk for you. The more you understand, the better questions you'll be able to ask. This is just another slide talking about shared decision-making. If we don't share the language in the conversations, how are we sharing the decisions? Let's share the language. Okay, so nuclear medicine currently is these imagings and these treatments. This is in the United States, and right now it's June 2023. This is current for the United States. Bone scan, which you commonly know just as bone scan, you often get it with a CT scan from your urologist or your medical oncologist. It's actually nuclear medicine because of the injection, which is technetium-99 or T99, okay? Other nuclear medicine imagings are any type of PET scan. By the way, every PET scan is different depending on the injection, okay? PET scans aren't all the same. In prostate cancer, we have the Axumin, which is fluciclovine, Axumin being the brand name, fluciclovine is the generic. But I think people are most excited about our newer PET scans, which are PSMAs, and we now have 3 different PSMA PET scans FDA approved: Pylarify, Illuccix, and Posluma. These are all nuclear medicine on the imaging side. Nuclear medicine on the treatment side is 2 things right now in the USA. One is Xofigo, generic term is radium-223. 2 is Pluvicto, the generic term is lutetium-177. I think I'm pronouncing these right, and I can always look over here in case I'm not. So, just for clarity, nuclear medicine in prostate cancer is not these things. It is not an MRI, including a multiparametric MRI. That's not technically nuclear medicine. Not CT scans, not DEXA scans, not ultrasound, not X-ray, okay? In treatments, nuclear medicine is not hormone therapy, immunotherapy, chemotherapy, or radiation treatments that you receive in an external delivery, external beam radiation of any kind, just for clarity. By the way, the last slide has my email address on it for people on YouTube. You can email me and I will send you these slides in a PDF format so you can review them at home. Okay, the word nuclear is the issue here. You know, I seen the movies, right? And I know what I associate it with. So immediately we have to clear that up a little bit and apply it in a different way to medicine. So the common perception is nuclear is always dangerous, right? Not always. That's a misperception in medicine, because everything in medicine, you're trying to weigh the risk, that's the danger part, with the benefit. You have to look at both. None of these treatments would be on the market if the FDA didn't evaluate them on both risk and benefit. So when you're looking at your treatments and your scans even, always try to look at both. Talk about both, write it down in 2 columns. This will give you more clarity for the questions you need to develop for your doctor. Another misperception is nuclear medicine is always a treatment because it's medicine, right? Well, it's a little bit of a misperception, because the radiopharmaceutical, put those together, radioactive pharmaceutical, that is injected for the imaging is actually FDA approved. So it's not exactly a drug, but anyway, it's nuclear medicine, and it is FDA approved because it's a radioactive pharmaceutical. So it's both imaging and treatment. I hope this is, helping clear up some basic information. Nuclear medicine imaging, now which doctors give this imaging, right? So it would be a nuclear medicine physician like Dr. Berenji here, or it would be a radiologist, not radiation oncologist, those are 2 different doctors, radiologist who does imaging, but he probably has some special training in nuclear imaging in addition to his radiology. Nuclear medicine treatment can be administered by, right? These are just common questions for patients. Nuclear medicine physician like Dr. Berenji, or, believe it or not, it's a radiation oncologist, the doctor you went to for your external beam radiation, can administer nuclear medicine treatment, which right now is Xofigo and or Pluvicto. So I think this helps patients to decide who they might need to make an appointment with for questions. So again, basic information. Just to be clear, it cannot be administered by a urologist or urologic oncologist or a medical oncologist. However, they are your clinician and they will send you to a nuclear medicine physician or a radiologist for the treatment. Okay, so I want to give you some ideas of questions. And again, on YouTube, I will email you these slides if you send me an email, that if you're newly diagnosed or recurrence, that you could ask your doctors, plural, and let me throw in nurses, doctors and nurses, about nuclear imaging. We all need to know, want to know, will insurance pay for this PSMA PET for me? If not, what makes me eligible for coverage or payment? Here's another one, it's important. What percentage of prostate cancer patients don't express PSMA? Those patients, I would then next be asking the doctor, if I'm one of those patients, does an Axeman PET scan make sense for me or something else? Great questions get you great answers. Better questions get you better answers. On my PSMA PET, and Dr. Berenji and Dr. Patel are going to help us with this. Okay, by the way, if you've ever heard me talk, you've heard me talk about getting actual copies of your medical records. You must have your own. My doctor has them is not good enough for shared decision making. Have your own copies. But on your PSMA PET scan, there will be an SUV. No, that's not a vehicle. I know what it sounds like, but it's not. But it stands for standard uptake value, correct? Thank you. I'm not going to explain it. I'll let Dr. Berenji and Dr. Patel do that. However, the number may be of interest to you. In simple terms, usually a higher number means that you have more expression on the PSMA PET. Is that fair? Okay, I'll let them take that on. And of course, always, how do I get a copy of my dictated written report from my imaging? When you have any imaging, you should have a copy of your dictated written report. I know you have the disc or the CD or whatever. That's good for the radiologist, the nuclear medicine physician, because they know how to read it. But you need the dictated written report. Make sure you have a copy. Okay, for patients with recurrence, now we're going to talk about nuclear treatment. There is no nuclear treatment right now for newly diagnosed, so we're just talking about the recurrence category. So here are some questions that you might ask. Do I have what's called CRPC, castrate-resistant prostate cancer? Okay, this is something you should know. You can Google that very easily. If I am CRPC, does my imaging, I don't know what imaging you've had, but does my imaging show me as metastatic, MCRPC? If so, when does Xofigo make sense for me? When does insurance cover it? When does Pluvicto make sense? When does insurance cover it? Mike, how am I doing on time? I'm good. Okay, thanks. All right, so for further information, I am going to send you to SNMMI. We are part of the Patient Advocacy Advisory Board for SNMMI. I'm going to come back to that in a minute. Our patient website, but also get used to and think about just going straight to the product website. There's a patient section, not a physician's, but a patient section. They usually have good information. They're regulated by the FDA. It's got to be accurate. They cannot overstate. So we've got Pylarify, Illuccix, Paxlovid, and Axemin for imaging. Then we've got Xofigo and Pluvicto so that's a good start. But I'm also going to recommend Prostate Cancer Foundation, honestly, in my opinion, as a 20-year advocate, probably has the best prostate cancer patient guide. They update it constantly. They're just very, very good at it. You can get a PDF copy downloaded to your computer, or you can ask for a mailed hard copy guide. So honestly, that's my best go-to if I was to try and recommend one. And even in the last month or so, we've had 2 things FDA approved. We've got another treatment regimen. So it's hard to keep up, and they do a better job than anyone I've seen, to be fair. There's also cancerabcs.org. That is our website. There's some great information there. And my other personal favorite is pcri.org. Probably their YouTube channel is one of the best ones. And full disclosure, I worked there for 13 years, but that was a long time ago. But I think their information is good. It's accurate without overstating, and it's very down to earth. So who is SNMMI, just for information? Society of Nuclear Medicine and Molecular Imaging. Nuclear medicine we just covered. Molecular imaging is just another way to say nuclear imaging, to be fair. So, but they have a Patient Advocacy Advisory Board. There are 17 members representing all kinds of different disease states. For prostate cancer, there are 4 of us who represent you or try to represent you. Sometimes it's on Capitol Hill, sometimes it's with doctors, sometimes it's straight to patients, but we're here to advocate for you and to try to be your voice as best as we can. We have Hal Berger, who is very good at government relations. He's with Zero Prostate Cancer. Mike Crosby, Veterans Prostate Cancer Awareness, myself. And then we have Mike Philbin, who is a PC patient, but he's BRCA2 positive. He works for FORCE, which is Facing Our Risk of Cancer Empowered, and they specialize in genetic mutations, genetic information, BRCA1, BRCA2 being the most common, but that's who FORCE is. So that's who we are. You can look us up online. There are always questions. If you do have some, I'm giving you my email address, and then my partner, or our CEO and co-founder at Cancer ABCs, which is Joel Nowak, along with his wife, Wendy Lieberwitz. So feel free to send us an email. We'd be happy to follow up. How am I doing on time, Mike? Oh, I got 7 minutes. Good. Questions? YouTube, audience? Oh, come on. Somebody's got one question. All right.
Jan, I have a question.
Thank you, Mike.
Could you please tell us when the patient kind of get-togethers that you have around the country are, and what the new ones are coming up?
Thank you, Mike. I produce patient conferences. They're very patient-first in multiple ways. They're actually different than many other conferences because of that, including everyone gets handouts from the slides. We do live Q&A. Our next one will be Saturday, November 4th in the Villages, Florida. We will have Dr. William O. We have a genetic counselor. I do a radiation panel discussion and a lot of other things. Saturday, November 4th in the Villages, Florida. Thank you.
You're welcome.
And it's free. Conference is free, lunch is free, because that's how it should be. So, all right.
I have a question for you.
Okay.
One of the issues that we see is access to digital media. So do you have other methods of delivery information for patients that are either not capable or unable to access the digital media?
Access to digital media, do you mean like,
internet, or they don't have a tablet or
Oh.
computer at home. So those are the population that may be kind of
the most
left
affected?
so that's something that always comes up, and
That is a great
yes,
question.
either due to various reasons, well, the population we are dealing with, like homelessness, is an issue. So even they don't have a roof on their head, so it's
The
really hard
patients
to
with the
get some-
greatest need is what he's asking about, and they may not have internet. They may not even have it on their phone. Yeah, Mike, you
Can I
want to
say
answer
something?
that? Yes, please.
We have, and Dr. Brangi, so we have an agreement, we just reached an agreement with,
Veterans.
for veterans that are in clinical trials that have no access to phones or internet access. T-Mobile has volunteered to give us free time, free plans, and free phones for vets that are in clinical trials. So it's another reason to, if you're not a vet, you need to get in the VA, or if you are a vet, get into the VA, and you'll get the best prostate cancer treatment possible. So, that was approved, so we can help you with that.
Very good.
That is such a great question. I'm going to pause and say, if you do want to ask me more about that, go ahead and email me or any of us up here. I will find you the information because that is a key question. So thank you for that. Okay. I've got 5 minutes left, but since we started 4 minutes late, I think we're good. Oh, okay. Okay, last call for questions. Anyone on YouTube? Anything? Okay, I'm just going to pass it on then to Dr. Berenji. Thank you. You want to self-introduce?
I can do it.
You got it?
Sure. Just Hi, everyone. Thank you for inviting me today. I'm Reza Berenji. I'm currently working at VA hospital at Los Angeles VA. I had an opportunity to work with Bing for some times, and all the exciting things happening with prostate cancer, I had the opportunity to be able to offer it to some of our patients. But still, there's a lot of work needs to be done. So I'm just, I was debating if I want to put slides or not, because you probably get a lot of this information on the internet. But just to start with something, I have a few slides that I'm going to go over, but I hope that we spend more time on question and answer. One important thing that I want to say that some years ago I attended a meeting just like this, and that we have one prostate cancer survivor talking to the doctor. So it's very important that we listen to our patients and learn from them. And I learned a few important things from that cancer survivor. One of the important things that I'm using in my own life is, he said, always go to your doctor prepared, and that's what Jan was saying. So have the right questions and write it down and know what you want to ask, because even I'm a doctor and I go to my own doctor and all of a sudden I forget everything. So it's good to be prepared, ask the right questions, and this is your body, your health, and your life. So you just have to be, the advocate for yourself. So, and I work with many patients, different type of cancer, and I speak with them and their family, and I always appreciate any question that comes to me. So this is very important, and as a physician, I'm always like to hear from my patient and get feedback. So getting back to, I think Jan did a great job in terms of imaging and nuclear medicine. I think a few years back, because of the same sort of question, I guess the society was called Society of Nuclear Medicine, and now it's called Society of Nuclear Medicine and Molecular Imaging. So it kind of shows the expansion of the field. yes, the name nuclear and radiation brings some fear with it, but as much as we can educate others and educate ourselves, the doctors, we have to educate ourselves, our colleagues, other doctors, so I think that will help. So in terms of modalities or imaging for prostate cancer, we have bone scan, we have PET scan, or it's standing for positron emission tomography. I can speak all these jargons, and but I just don't want to go into a lot of details, but it comes up, so as a question. We have transrectal ultrasound, magnetic resonance imaging that can be multiparametric MRI, ultrasound fusion, guided prostate biopsy, computed tomography, and we can bring a lot of modalities, but end of the day, as physician, we have to bring it down to the level of our patient, and we get all sort of patients, sometimes, and most of the time, they're even more educated than I am, so I learn from them. So the humbleness and the acceptance should come to us as physicians to accept our patients and bring us down and speak to the level that is understandable. We can all say some jargons and kind of ignore if the patient understands or not, but it's important to bring it down to the level of the patient and make them answer all their questions. So what is bone scan? And bone scan, I don't get into the details. Most of these imaging are done by injecting something mostly in the intravenous or IV or venous system. So it starts usually, some of these imaging, they need some initial preparation. Bone scan usually doesn't need any preparation as long as the patient is well hydrated. That's good enough. They can eat or drink anything they want. They come to the clinic. It usually takes about 3 or 4 hours. So we give the patient heads up because some of them working, so they have to be prepared. They need transportation. So these are all important communication that sometimes, unfortunately, may not translate into the patient. It adds to their anxiety that they come, they think it's like a half an hour appointment, but then somebody tells them, oh, you have to wait 5 hours. So I think before starting any of these, a good line of communication is important to have with our patients. So what does a bone scan show? It usually shows where the disease is in the bone. It basically says what it's done. And when is it done is whenever, in terms of prostate cancer, when there is a suspicious for extension of disease to the skeletal system. That's mainly what bone scan shows. And these are some images of patients. The one on the, I think it's your left side, I guess. I think it's the same way, left side. That's a normal scan. I think my pointer works here. As you see, we still see a silhouette of the body, so it's not completely a bone scan. We still see some non-bony areas of the body, and sometimes it's actually the only findings that we see in a bone scan. We see the kidneys, and if there are some type of cancer or diseases in a non-bone area, it's also can be seen in some instances. And some areas are that are darker in these images, like in the shoulders. It may be due to arthritis or degenerative changes, sometimes due to trauma. On the other hand, on this other side, this is an unfortunate patient with extensive disease. All these darker areas are the areas that prostate cancer extended or metastasized. So that's, unfortunately, that's what's happening in some patients, and we try to first diagnose it and find proper treatment and alleviation for them. Now, PET scan, as Jan mentioned, there are, so the PET scan is usually at this time, any place you go is called PET CT. That's a combined imaging. So the PET part, or positron emission tomography part, is done by injecting some radioactive material, which is called radio tracer. One of the most relevant type is the prostate-specific membrane antigen, or PSMA scan. Fluciclovine or Axumin, it was good for some time before PSMA. It's still used, is FDA approved. Sodium fluoride is very similar to the regular bone scan, but it's it's done by a PET scanner or a PET camera. And there are some other radio tracers. So again, how a PSMA scan is done, very similar to bone scan. There is not any preparation, but it shows something different compared to the bone scan. Bone scan is, the way we call it, is not very specific. It shows anything that causes that kind of reaction in the bone, but the PSMA scan goes and shows any area that contains that prostate-specific membrane antigen expression. But not all areas with that kind of expression are abnormal. Some normal parts of the body also show that kind of activity and uptake. And it's usually done anytime that we get a patient with newly diagnosed high-risk prostate cancer or unfavorable risk at the initial diagnosis, and then later on, depends on PSA level going up, we may decide to do PSMA scan, and now we do it before doing the PSMA therapeutic. So this is just an example of PSMA scan. As I said, this is a almost normal scan. Areas like salivary glands, liver, spleen, kidneys, and part of the ureter and bladder, and intestines also show activity. So these are normally seen in all patients. So if one of you gets one of this scan, don't get scared that there are some activities. There has to be. This is kind of normal. But in this other unfortunate patient, these other areas that you see right here, that actually looks pretty dark. This is the bladder, but the areas around it are unfortunately extension of prostate cancer or metastasis. There are, as Jan said, different types of PSMA scan. They're very comparable. This type is called PSMA 11. The previous one I showed, this is called Clarify or DCF-PYO. They're very comparable. This is a newly approved, I think it's a few weeks, postoloma, and I took this image from another article. It's not exactly postoloma, but it was just the best I found at the time. So very similar activity in the salivary glands, liver, spleen, kidneys. So these are the normal areas, but this particular patient had this abnormality here. Now, Axumin or fluciclovine is very similar to other type of PET-CT. The major difference in Axumin is we put the patient on the camera, prepare them for imaging, and then as we inject the patient, and a few minutes later, we scan them. On the PSMA scan, we have to wait about an hour, so that's the wait time. The bone scan wait was 3 hours, 2 to 3 hours. But fluciclovine, within 5 to 10 minutes after the injection, we have to scan because we want to prevent the injection activity gets into the bladder and ureters. That's an important part that we want to prevent, basically. And this is a patient that had both scans. You can see side by side. Fluciclovine, usually you can see a background in the bone marrow and some other skeletal areas, while in the PSMA scan, those areas are not very well seen. Now, there is a PET bone scan, or sodium fluoride. It's very similar to the kind of the other type of bone scan. But what it does, first of all, it's faster, so the whole thing can be done in about an hour and a half or 2 hours. The wait time is about an hour. It's, again, injected through the IV system. We wait about an hour and then get a bone scan done. And the images are very accurate in terms of showing different areas. So as you see in these patients, as we go to the right part of the screen, they show more abnormalities, and the last one on the right has unfortunately a lot of abnormality due to extension of prostate cancer to the skeletal system. This is a good modality. It's not widely used. It's limited to certain centers, but we use it at our center. Nowadays, most patients with prostate cancer get a PSMA scan more frequently than a bone scan. So there are other tracers that beyond our scope today, but there are more on the pipeline, and we are very excited. Our practice has significantly changed since we started doing PSMA scans. So the whole research about care of the patients and how we recognize progression of the disease, I think have been changed in the past, I think since 2021 that is improved widely, but in our center, because of the importance of PSMA scan, we started doing scans in 2018. It was almost 3 years before the approval. And I clearly remember that my extended access program, as we got everything going, then the pandemic started. So there was a question. Most research activities stopped at a time, but I was able to go to the management of our hospital and the research department and make my case that this is an important and valuable part of care for a patient with prostate cancer. So I opened the trial on April 7, 2020. And during that time, I was able to provide very highly needed imaging to our veterans. So and they flew from all over the place because we were the only one offering it at the time. But it was a pleasure working with all of them, and I think it made a huge difference in their care during that time. That was very stressful for all of us, but people with cancer and chronic diseases particularly. So that was a important one. So I always put this for everybody. The SNMMI always are doing a great job. This big arrow in the corner is referring to patient resources. So please go to the website and use that. There are many other resources, people like Bing and Jan, and I always keep contact with patient advocates and with our patients because I learn a lot from them, and I think that's a valuable part of my practice. Now, in terms of other aspect of nuclear medicine is which is becoming excitingly pretty big part of our practice since approval of, I think radium was pretty game changer at the time that it came out, but now it's overshadowed by PSMA therapies and Pluvicto, but still we have patients that are getting some benefit, alleviation of their pain by radium therapy. The samarium and strontium, they were used before. I don't think they're available in the US anymore, but you can probably, if you're overseas, some places are still offering them. But more or less, radium is available. That's called Xofigo, and in some patients, it's helpful to alleviate their pain. Now, the big and major things that happened was last year approval of PSMA, once lutetium-based PSMA therapy with Pluvicto approval. But that was just the beginning. A lot of exciting clinical trials have been started, and some already concluded to expand the access. The initial approval of Pluvicto was people with who have gone through chemotherapy, so basically as a palliative care. But now we have other trials looking into people um, without going through chemotherapy or even hormone sensitive. So it's getting expanded. That's the hormone sensitive metastatic prostate cancer. That's pretty much majority of our patients. So it's here to stay and hopefully save more lives and help our patients. And this is one of the patients that I treated I think about 2 years ago. So this is the PSMA scan, and you don't have to be a nuclear medicine physician or radiologist to see all these black dots. These are all, unfortunately, disease in the bone. So we usually do another type of PET scan, which is called FDG, and is based on radioactive sugar or fluorodeoxy glucose. We do that as a part of consultation to tell the patient what to expect from their treatment. It's not, so this is kind of off-label, it's not kind of approved for this type of things, but we do it as a consultation to our patients. And this is after 3 doses of Pluvicto. And again, you don't have to be a radiologist to take. Most of my patients want to see their images, so and it helps to see how widely their disease is, how local it is, and which area. And when I show them, oh, I know where my shoulder pain comes from. So because they don't see it, but when they see it, it kind of registers in there. So that brings more compliance, more understanding of the treatment, and more questions most of the time. And then we check the PSA level or prostate-specific antigen level of this patient, and it started with almost 100, and after the therapy went almost undetectable. So, but I always tell my patient, this is not a cure for your disease. This is just delaying the extension. So we have to be reasonable. We have to be clear about our communication and provide accurate information to our patients and answer all their questions. So, but I just put one slide for the importance of safety of these procedures. And there are many levels that all these products go through, and then how we do our imaging or therapy, and then after the procedures that we have to keep our patients safe. So at the production level, all of these are under certain regulations, FDA regulation, and many other organizations are involved to make sure that we safely produce the right type of radioisotope, radio tracers. While all of those are done, then the patient comes to the clinic, we have to follow certain regulation to properly identify the patient, give them the right dose, the right route of administration. Not everything is going through the IV. Some of these are ingested or injected on their skin. So we have many different procedures, and we get patients coming at the same time for different procedures. So we have to be able to identify them and give them the right dose, the right route of administration. And after that, when we send the patient out, we have to give them instructions about their safety, their family's safety, and the public safety. So these are all important things that every certified person doing this kind of procedure has to follow to make sure, first of all, not harming the patient, and secondly, keep the patient, their families, and public safe. And with that, I guess my presentation, that's a Griffith Observatory in LA. Hope everybody comes and visit us.
Does anyone have any questions?
Yeah, any questions? And then if you think of something on the way, we'll have some time later, and then after this is going to be our reception, so you can ask. We can have discussions then as well.
I have one question. Can we
Yes,
go
dear.
back to the lutetium-177 slide? I think it's 2 slides back. This patient, Dr. Berengi, I mean, obviously these images are really striking and exciting. Every man wants to see this type of response. When this patient got down to the 3rd therapy and the PSA of 0.17, can you tell us, do you remember what are his side effects at that point? How were his blood counts and how were his salivary glands? Had he gotten any worse than just dry mouth? How is he doing?
Yeah, great question. So this patient was on a wheelchair before getting that kind of therapy. So he was so much pain. He had failed on Zofigo. He had gone through many rounds of chemotherapy. So basically, he was almost end stage. So after that, we gave him some time to have a little bit more quality of life. His pain has reduced substantially. And he didn't have that much dry mouth, although we were expecting to have. And here's what happened when there's a lot of disease going on. So majority of that harmful radioactive material for the disease gets absorbed by that. So then activity in other normal organs is a little bit less. But as you treat more, then there is more of the radioactivity may end up in more like salivary glands and the bone marrow and other area. But majority of patients show some level of lower level of blood cells. It can be anemia, low platelet counts, low white cells, so there's some limits. So this particular patient, we had to delay therapies and reduce the dose because of the blood cells were low. So they need transfusion sometimes. But when you put it in perspective that we give them some time without a lot of pain, and then he was able to do some activity, I think the risks and benefits, the same thing you showed, the benefit was higher for this patient. And we get some patients that may not be a good candidate for this kind of therapy. What is very important is to recognize who is a good candidate for each type of therapy, because you don't want to, first of all, get false hopes and waste the patient's time, because they can get some, combination of other therapy so that's very important. But thank you for the question. It's very important. And we regularly check the patient's blood count, the liver function, and kidney function, because these are the organs that may be affected by this therapy, and we have to make sure if it's necessary to stop the treatment temporarily and sometimes permanently, or reduce the amount of those activity.
Thank you so much for mentioning the idea that a treatment could be decided between patient and doctor to either lower the dose or pause and make a longer wait for the next dose as part of the risk-benefit that's best for the patient. Did I hear that right?
Yes.
Because that helps patients, it helps empower them to actually ask that, because many patients don't even think they can ask that question. But if your side effects are just too much for you, you need to speak up and even feel free to ask the doctor about the idea of balancing better by lowering your dose maybe, or extending the off time. Correct? Is that fair?
Correct. And then I had patients that they had to get surgeries for other reason. I had a patient that had to get his, lower leg unfortunately amputated. So we had to work with the surgical team. It was for other diseases not related to prostate cancer.
Yeah.
Well, we had to coordinate the time of therapy, so we delayed the delivery of a dose. So he went through surgery. When it was safe for him to receive the next dose, he got it. And I have to say that last week I scanned him after 6 months that he got his last dose. There was no disease, so he was still in remission. So that was kind of a boost for me coming to this meeting to hear that successful story.
Understand that. Any other questions? Yes.
I'd like to thank you, Doctor, for a wonderful presentation. Just two quick questions to follow up on the MRI of the prostate. You listed the multi-paramic MRI.
Sure.
And I was wondering from a patient's perspective how a patient would know whether the prostate MRI they got was something other than a paramic MRI. And a related question, there seems to be in the practice a great deal of difficulty or ambiguity in reading prostate MRI images, and in identical, very highly qualified experts reading the same MRI and the same images, seeing no increase in size of a tumor, seeing a decrease or seeing a significant enlargement. And I was wondering if you could just comment on how, from a patient's perspective, they could interpret or help to try to understand that.
Sure, excellent question. I had the same discussion 2 weeks ago. We started a new clinical trial. It's just local at the VA. So we're just going even more, and we're looking into to see if the PSMA PET-CT has any value before doing the biopsy even. So as a result, we get patients, one group gets only multiparametric MRI, and the other group multiparametric MRI plus PSMA scan to see. So what I'm trying to say, we were looking at some reports, and we have our own radiologists also looking at the images, and there was a lot of difference of opinion. So, and we were thinking what to do about it. So we decided to just based on the report, because as you said, two readers may have difference of opinion. So it is, so there are many things. It's just the nature of the MRI scans. There might be some artifacts. MRI can show something that from a look of one reader and their expertise, they, define it as level, like, I don't know, they call it PIRAT, like 2 versus 3 versus 4. But it is very modality, very reader dependent. So do you have any comments? So you get into this
Yeah, I would just say that I guess
frequently.
that gets a little bit more relevant also in the localizer initial diagnosis time, or time of that initial diagnosis. So, we looked at this also when I was a fellow at Loyola. We looked at it. I'm looking at Northwestern, but the variation that's there, I think ultimately, if it's most important at the time of detection, or if you're looking at local staging when you're getting your first treatment or initial treatment, and I think at that point it's also important for our communication with our radiologist to say, hey, I'm not the expert here, but can you tell me that I think they have a suspicion of prostate cancer, I think they have this suspicion, how do we work it out? And that kind of helps us decide, should we do a biopsy, even if they say there's no definitive lesion, but based on their family history, other clinical factors, can I use the MRI and say where is something more likely or not? So I think that's kind of provider to provider communication can help there. And again, yeah, depending on where you do MRI. So it's nice to work closely with your radiology.
Sure. Yeah, and there are publications we experience also sometimes there is high suspicious of prostate cancer, and even biopsy comes back negative, MRI is negative, so there are papers out there, they use the PSMA scan to help them. But that's why we're doing all this research, and hopefully we can show there is a value, and then it become available to certain group of patients with negative. And then your other question about how we know that because there's pelvis MRI and there is multiparametric, and then sometimes it gets confused for various reasons. It may not, the radiologist may not be trained to read those kind of scans, or it may even order differently. So line of communication between patient and their physicians and among physicians are very important. So, and unfortunately sometimes we fail. So we order something, and then it goes and it comes back at something different. So it is very important. So that's why when Jan said have your reports with you, it's important. So your provider looks at it and it doesn't say multiparametric, it say, pelvic MRI. So that's, at least if it was not the right one, so you can request the right type of
Dr.
question.
Patel, have you ever seen a multi-parametric MRI report that didn't say multi-parametric? So that's where you would start. If your report doesn't say MP or multi-parametric, it may not be.
Yeah, I think as long as it says prostate MRI, because I see pelvic MRI as the one that they were looking for something else. They happen to catch the prostate. They might see a lesion, but it's not the quality time of MRI that's going to help us make a decision. So it'll say pelvic versus prostate. And then multi-parametric, I think as long as it says it's a prostate MRI, because issues in Europe and a lot of other countries, they may use biparametric MRI, which has been shown as long as you have a set threshold to be equivalent if you're going to biopsy all men with the PIRADS 3 or higher tumor. And so if you hit that PIRADS number of should we biopsy or not, it's the same, but they will use the word biparametric versus multiparametric, and that depends on if you've got contrast. So if they gave you an injection of contrast, then it's multiparametric, and if you didn't get an injection of contrast, then it's usually biparametric.
And if it has a PIRAD score on it, it's one of the two.
Yeah.
So that's
And-
probably, if it
yeah,
doesn't
and,
have a
yeah,
PIRAD
introduction
score,
of
that's a flag.
PIRADS. Introduction of PIRADS was to standardize it, so make it more interchangeable between readers, but still there is some differences between readers.
I'm going to add one thing, Dr. Patel, if this is okay, but ACR does have a booth down in the exhibit hall, and they are the authors of the PIRAD document, and they may be able to give you a list of experts for multi-parametric MRI. I don't know, but I'm happy to talk to you if that's helpful to you. And again, multi-parametric MRI is not nuclear medicine, but it's really important imaging, so it's a great question. So.
Yeah, definitely.
yeah.
And then one thing that I can add is with the use of more artificial intelligence, we can kind of use the help of the software to standardize things. So that's one thing that maybe in the future help the radiologists to be more accurate and give a better reports. But it's yet to be established. It's not still under research.
Any other questions? Mike, how are we doing on time? What do you mean by okay? Give me a number.
We're all right. We're technically over, but we're going to let Dr. Patel come and give us his view of things. This kind of thing. There you go.
Okay, thanks for having me, everyone. So, yeah, my name's Heath Patel. I'm an assistant professor of urology at Northwestern, and I'm a urologic oncologist. So primarily, I'm a urologist, but I work very closely with our radiation oncologists and our medical oncologists and radiologists very closely on a multidisciplinary team. So even though I'm usually the one patients are seeing at diagnosis or kind of their early discussions, and some of these imaging modalities are even more relevant for advanced prostate cancer, we still participate in and really much, very much take care of these patients as well. And so, the two things I was going to talk about first is, does it show what we think it shows? So nuclear medicine, I was going to focus more on basically PYLARIFY, PSMA PET scans, and then just the concept of a false positive and how I think about it clinically. So I'm just going to give you an overview of kind of my thoughts on how these things are starting to be used in the last even just 2 years as they've become available, and what situations, maybe just a couple examples, but if anyone has or wants to interrupt at any time or talk about any specific examples, I'm happy to expand there too. So, first question is, does it show what we think? And so for PYLARIFY, there's a lot of studies, and the Osprey study was really what started, I think, a lot of the data on how good is it. And this was done, I was a resident at Johns Hopkins when they were studying this tracer, and Marty Pomper was one of our nuclear medicine physicians there, and they were doing a lot of these early studies, and it was really exciting to see this come out, just 2 years ago, and really is what kind of changed and why PYLARIFY kind of started. So in this study, the part that is very relevant to urologists is if I see a patient, I've diagnosed them with what is high-risk prostate cancer. Traditionally, I would get a CT and bone scan and say, hey, does anything show up on the CT and bone scan? If it doesn't, I consider them localized, and if it does, then I would consider them to have distant disease, and we would need to maybe get others involved. But when it's localized, treatment often involves a urologist, a urologic oncologist, and often a radiation oncologist if it's not spread outside the prostate. But what happens is sometimes we're wrong. We did the CT bone scan, and it turns out they actually had a bone lesion or a lymph node that had cancer in it. And then sometimes the questions come up is, well, did we do them a benefit by doing this local treatment when our goal was to, hey, try to cure it, and now we know it's already in the bone or somewhere else? Should we have offered another treatment up front? And so this is an example of how PYLARIFY has kind of changed some of our thinking, is that if I have a high-risk prostate cancer patient, it is totally reasonable and totally a standard of care to get a CT and bone scan. In my practice, I've started getting a lot more PSMA PET PSMA PET scans at the start instead of a CT or bone scan. There's a lot of controversy. Do we need all of it? Do we need all of these scans, or was one good enough? And if you look at just PSMA PET scans by themselves, if a lymph node on that scan turns out to say, hey, there's uptake and it meets our criteria to say it looks suspicious, how often is it right? And based on how they did this study, 87% of the time, it was right. There was cancer there. If you look at a CT or MRI, they're just looking at really the size of a lymph node, and you say, hey, that looks enlarged, so we think there's cancer there. That's actually only correct about 30% of the time in this setting. And again, depends on your PSA and a lot of other factors, but of the men in the study, finding that criteria is only right 30% of the time. That's what our standard of care really was. And this shows that, hey, when it shows up on PSMA PET, we're a little bit more confident. Well, what about if it doesn't show up? So if it says, hey, the CT MRI said there's no cancer, or at least the lymph node was not enlarged, how often is it right? And it's pretty accurate, almost 80%. And the PSMA PET scan, thankfully, actually keeps up with that if it doesn't light up, it's not perfect, but it's right 83% of the time. So there's some men that we're missing that do have this, but thankfully, at least when it's positive, we get a lot more benefit from this PSMA PET scan as opposed to our traditional kind of imaging on just size of a lesion. So that's just kind of one example where I often see men and where we often use it. And there's pluses and minuses. If something's uncertain, you have your backup. You could still do the CT and bone scan, compare it to your PSMA PET. But I think for most men, it's usually one or the other that you're going to go down in terms of staging. And these are just more technical numbers. This is showing that regardless of how the positive and negative results, which is, I think, the easiest way to think about it, the sensitivity is how often of all men that have this cancer that's spread outside the prostate, how often are we finding it? And actually, it's not that great. It's 40%. So there's a lot of men who have microscopic disease or tumors that may have already spread that we find a little bit later on in treatment. But that's actually the same as CT and bone scan was doing. So it's 40%. So unfortunately, that sensitivity has really not changed. But when we look at lymph nodes that are a little bit bigger, not very tiny ones, but ones that are at least 5 millimeters, just a little bit bigger, still well below our 1 centimeter, what we think of as suspicious, then the performance gets much better. And so the thought here is that, obviously the smaller your lymph nodes are, even if you had a microscopic amount, it may not be perfect, but if they get a little bit bigger and definitely better than when you saw it on CT or bone scan, it's a much better performance. But these are technical numbers, but I just wanted to say this is the stage where I see it the most or use it the most. These are some examples of scans similar to what you had seen before, but on the left is a bone scan that looks largely normal, and there's no things that stick out outside of what we might expect. And on the right is the PSMA PET scan, and that shows spots that we didn't see on the bone scan. So if I had just a CT and a bone scan, you may not have seen this in this specific individual, and then we see it in this man on the right that the PSMA PET scan really picked up spots. And what the studies were doing is that we see these spots, but are they real, and do they really turn out to be cancer? Are we just seeing spots and they're not actually things we need to treat? And most of the time it turns out they are correct, and that's really why we did these studies in the last 2 years. The scans have been used more often. And the other setting where we think about it is that, well, what if somebody had prostate cancer treated, or initially we think they have a more advanced prostate cancer, someone who had a recurrent or metastatic cancer. And just to simplify it to say, well, this is a study where they actually biopsied and said, hey, if we see a spot that lights up, how often is it right? And the sensitivity is quite good in this setting, 96% for PSMA PET scans. And that means 80% of the time when something positive showed up, they biopsied or they got as good as they could to really proving that's really what it was. Doesn't mean that those 20% weren't positive. It may be that they just couldn't prove it, but it's quite good, and that we can, if we go after and find the spot, it does show up often. And so that probably means that we don't need to chase it for all of our standard of, in clinical practice for everyone. Do we need to actually chase all of these spots and prove with pathology that it's something that's actually cancer? That's why we do these studies, and they show that, hey, it's quite good, and there might be some people where we're uncertain about it, where doing biopsies help. And this just shows that if your PSA is higher, it's much better. So if your PSA is less than 1, the positive predictive value, or how often is that positive finding real? It's a little bit less. It's between 40 to 60%. But when your PSA is over 1, then you get quite good, and it doesn't really matter how much more. So if your threshold is someone has a recurrence, if their PSA is over 1, this is going to be a good scan. And I often use a 0.4, 0.5 threshold to say, am I actually going to see something, or is this something that I can keep following a patient? And as long as their PSA doesn't go up very fast and they've had surgery or radiation, if it doesn't go up that much, maybe we can keep watching it. But when you get over 1, for sure, these scans are very helpful. And in the last setting where, again, I often see patients is that we've done a radical prostatectomy. We thought they had localized prostate cancer, and they did, and their PSA may have gone to undetectable. But there's some men where it doesn't go to undetectable, or they have a later recurrence a few years later. There maybe was something microscopic, not making PSA, and it starts going up. So in this biochemical recurrence setting, how good is PSMA PET? And they found similarly 85 to 87% of the time they have correct localization. So if something shows up on that scan, we can believe it. If it doesn't show up and their PSA is going up, we still think they have prostate cancer, but maybe they don't have metastatic disease, maybe nothing spread outside of the pelvis, and we need to wait a little bit longer to really tell us what's going on before we commit them to a treatment that might be more invasive. And in this study, 64% of men who had this scan basically had a change in what they would have had they not had this scan. If they had their standard CT bone scan and looked at their PSA, there was a set plan intended. Then as part of the study, they got the scan, and they said, well, how often is this going to change what we're going to do? And then the last thing I'll mention is a false positive. So as I mentioned, there's things that may show up on the scan. Sorry, I'm on call, so just wanted to make sure. That page isn't anything, but if we see some findings, and sometimes this is when we see just one spot on the scan, we say everything looks like we expected, but somehow there's just one exact spot, and it's in a rib lesion, it's in this spot, is it real? And that's the setting where we often see a lot more false positives, and that's where the SUV or the intensity of the pickup might be able to help tell our nuclear medicine colleagues, is this something that's real, or is this something that we've gotten used to seeing? And we were talking about variation in MRI, and I think there's going to be the same thing with PSMA PET, of variation in saying, we see these spots, and one nuclear medicine physician may see it and call it something, and another person may say, actually, that's a false positive. And a lot of this is experience dependent, that they've seen it enough times, it's been described enough that we can tell this is something that we don't need to worry about right now, or something that we really need to follow or act on in treatment. And these are just some examples of other things. There's skin uptake, desmoid tumors, other places, and then physiologic, as Dr. Brenji mentioned, the liver and salivary glands. We expect them to have uptakes. That's why you see bright spots on everyone's scan. But in these specific other scenarios, which I really think relies on the radiologist's experience of telling us, is this something I should worry about, is very helpful. And so, I'll take questions at the end, but basically the second part is similar to how you talked about, well, what can we do with these findings? We saw these findings. I said 64% of men may have a change in their treatment if they have recurrence, but what's actually being done? And one is actual targeted treatment, lutetium-177, the Pluvicto. And then the second is, one thing I'll describe, I'm also part-time at the Jesse Brown VA Hospital, and one of the studies we're doing at the VA with our radiation oncology colleagues that started at Hines is saying, well, can we use this information and can we target it to see if we can get patients better outcomes? So the first thing is just Pluvicto. And for Pluvicto, I was just going to mention this one study, the VISION study, that really emphasizes what Jan mentioned, that patients who have metastatic castration-resistant or hormone-resistant prostate cancer, do they benefit? Is this a palliative treatment, or is this something that's really prolonging their life or reducing recurrence? And in terms of helping with symptoms, that's great, but this study also showed that in these men that are candidates for this treatment, those are men who have PSMA PET lesions that show up on the scan, and then there's no spots on something else that showed up that didn't take up that scan. So if all of your cancer is showing this activity, then would doing a targeted treatment with something that targets that PSMA, that same protein in your prostate cancer, will that help you? And this basically just shows that those men who are this is really end stage and we're trying to bring it up, but what was their risk of progression or death? It was about 8 points, and I think these are how many months they survived. So if you had Pluvicto, it was 8.7 months versus only about 3 to 4 months if you were standard of care. So it really did increase survival. And you'd say, hey, this is marginal, but at the same time, it's almost 2 to 3 times as much. And those are many months that are potentially with less symptoms, better control, so good quality, potentially better quality of life than you would have had with potentially other treatments. And then the hazard ratio of death, again, increased about 4 months. So these are, small benefits, but in this most advanced setting. And what I'll mention is, can we bring it earlier into the disease process? So these are the studies that are going to bring it in to men who would have done well with several years of life on other treatments. Can we get them even more years of life, not talking about months, by adding this treatment in? We're going to really figure that out. We know that sometimes with men who have a little bit less amount of disease that's spread outside the prostate, even doing radiation locally to the prostate, if you've never had it treated, can actually extend life. So would doing this on top of that have even more benefit? And I guess one of the questions that comes up is, well, there's these lesions we're finding that we never would have seen on a CT bone scan. What is the new standard of care treatment? So I think now in the future, as we study radiation, surgery, all these things, it's now going to have to be done in the light of what does your PET scan or PSMA PET scan show? And the last question is, would treating these sites on PSMA PET help? And that's where I was going to mention the Starport study at the VA that we're doing, or that Avi Solanki is one of our radiation oncology colleagues at Hines started. It's for patients of oligo-recurrent prostate cancer. So you have recurrence, and there's a few sites where it shows up, not a large burden. And you pretty much previously had attempted curative surgery or radiation. What can we do? And so for these patients who have these limited sites of disease, they have metastatic prostate cancer, they're basically being stratified to getting standard treatment or doing standard treatment plus PET-directed therapy. So we see these spots that have lit up. Can we do small amounts of radiation, or is there a limited amount where surgery could remove that spot? And is that going to really extend their risk of extend their life is going to be the ultimate goal. But in this study, at least, does it extend how often they will be responsive to hormone treatments and not get castration resistant? And so these are the kinds of studies I think are going to come out and really going to change how medical oncologists, urologic oncologists, radiation oncologists think about these things. And just wanted to give you an example of what's being done in the VA for it. So I'll leave it at that. It's just kind of two sides. But if anyone has questions on discussion or building off what we had talked about before, happy to take them.
Are there any questions on YouTube? No? Anyone questions? Yay. I have a question too.
Hi, my name is Mike Philbin. I'm a volunteer with FORCE. So regarding the theranostics, I know right now it's palliative or it'll sort of extend care. Do we see a time, and just as a background, my dad was diagnosed with metastatic prostate cancer when he was 55, died 2 years later in 1974. Is there a time where we could see men with this advanced disease that their lives could be really extended? I know right now we're an extra 4 months, but again, in 2 years, is that an extra 15 months and 36 months and so on? Or do you see that possibility occurring in the future, I guess?
Yeah, I think, right now we're not there yet, but I think given how many things have just happened within a 2 to 3 year period, and I think we can't forget about our prior therapies, which is what that Starport treatment really showed, is really what it's trying to get at, is that we have Pluvicto and that, these kinds of agents that are coming out, but can we also combine it with traditional treatments that we have, radiation that can now be maybe more image guided, more focused, and if we knew which sites of cancer were the ones that were really problematic, the ones that, where's that cancer that actually spread, can we target those cells? Because the prostate by itself has multiple tumors sometimes, and it's, studies have shown that it's only sometimes one of those tumors within the prostate that actually led to metastatic disease, and the others did not, and the others are still in the prostate. We would have, if the biopsy missed that other spot, we would not even have seen it. Or that's why some of the patients with lower grade or intermediate risk, that we say, hey, I don't know how you had, how we missed it. It's because we only caught the lower grade tumor. The higher grade tumor that's spreading is there. So I think those things, in combination are going to be what's going to help. And I think if we catch them when you have these limited sites, I think it's going to be hard. A lot of patients in that study I mentioned were, had multiple rounds of therapy. They had tried all of the new hormonal treatments. They had docetaxel or some kind of taxane agent and had tried all those therapies, and then they got this treatment. If you gave this at the same time, back when they already did have years of life to live, even on those treatments, is there going to be benefit? It's a long study, because if they were going to survive 5 to 10 years on just the hormonal treatments, well, we got to prove, is it going to get to 15 years by adding this? It's going to take us 15 years to really prove it. But we see the benefit here. That's really how we bring a lot of treatments back. We see, and it happened with chemotherapies, immunotherapy. We used it at the end. We saw there was a benefit. Let's try bringing it a little bit forward. We brought abiraterone forward, brought enzalutamide forward, compared to where it was just a few years ago. And that's, I think, and hopefully that's where we'll see that benefit.
I have a question.
Oh, yeah.
Go ahead, Dr. Burns.
I have a comment. Can you hear me? Also, in addition to that, I want to emphasize, as a physician, not everything we do has to be based on the drugs and radiation and things. There we are getting, as physician and patients, more information about supportive care, diet, exercise, all sort of things that we have to include in our research. And I see the difference in my patients who are having a better diet and healthier diet versus the ones that are, and those are important things that we have to consider in terms of longevity of everybody, including the cancer patients.
Yeah, and I'll just add, we did a systematic review looking at kind of different diets and things, and really plant-based diets, as you might expect, healthier diets are often associated with that. It doesn't mean that changing your diet is going to help that much. And so one randomized study was the MEAL study that randomized men who are surveillance candidates, lower risk prostate cancer. Can we randomize them to getting healthier diets versus your standard diet? Does that extend their life? And it showed that, we were able to change their kind of health, even though it didn't change the upgrading or progression of the cancer. So I think there's benefits in overall lifestyle and all those things that we need to look at. And I think looking at patients who have are on these other treatments where it affects your bones and affects other things with your health, and even ADT, androgen deprivation therapy, now saying, hey, can this oral agent with relugolix the thought is that have less cardiovascular risk for patients who have had high heart attacks compared to standard Lupron injections, which is another study that Northwestern and the VA were opening to say, if we can prove that, then we have things that can help other aspects of your health, not just the prostate cancer.
Going back to the Starport trial in a previous slide, I don't know if you can go back there. Couple of questions. One, oligo usually means, it's defined right underneath, correct? 1 to 5 metastatic sites, and specifically for this trial, it would be on a PSMA PET, correct?
Yeah, so this is all those who have already had localized treatment. A group that we don't have is that if you never had treatment and at diagnosis you had 1 to 5 sites, would you benefit? And we know at least in those patients, there is a benefit, at least for local radiation treatment. So the goal of this is because there's a large proportion of men who did have, or we thought had localized disease and had that, but yes, 1 to 5 sites. And it could be in the pelvis, doesn't have to be 5, bone sites. It could be somewhere, a lymph node or something like that lit up.
And second, is this for veterans only, and what sites are recruiting? How widespread is this clinical trial?
Yeah, this is currently for veterans only. There are
Okay.
similar kinds of studies that will be, I think, offered, through the NIH that are at other institutions, things like that. Currently, this is a very VA-focused study and one of the ones that they were excited about. And I think it's still technically a phase 2 because it doesn't have enough patients planned for a survival
phase
outcome. It's about 200 some. But I think, the goal is hopefully if it showed a good result or good signal, they could maybe double or kind of extend it to work towards that, or open it up outside the VA to do that.
Is it still recruiting or no?
Yeah, it just started within the last year or two, and it's going to take, I think, another couple years. And so Hines VA was where
Where's
Dr.
Hines? What state?
Hines is here. So basically in the
Got it.
suburbs, Maywood, Illinois,
Okay.
right outside Chicago. So part of our Chicago VA system, but they're outside in the suburb. The Hines VA is
So
where
Illinois,
this is.
where else?
It's open at several cities. There's a map. If you look up Starport online, there's a website. It has a map of
Perfect.
all the VAs that are participating. At
Thank
Jesse
you.
Brown, since we don't have radiation oncology, we refer our patients to Hines, which is about
Okay.
about 20 miles away.
Yeah, we have it in Los Angeles as well. We
I'm
offer,
sorry.
we offer the Starport at Los Angeles.
Okay, thank you.
And Jen, there's 16 sites that are currently active, and
Thank you, Mike.
we've got a map on our website about where it's at, so we can help people get there.
Okay, we have one question on YouTube. You mentioned doing PSMA PET scans when PSA was at least 0.4 following radiation. At what PSA is biochemical recurrence sufficiently suspected following radiation?
Yeah, I guess so for radiation, so most of the patients that I see have had one or the other, or surgery followed by salvage radiation. So depending on if they had surgery first, whether or not they had salvage radiation, then I want their PSA to really be undetectable. And so at that point, my threshold is usually, for biochemical recurrence, that 0.2, 0.4 is kind of when we're thinking about it. And I found that at least if you do it too early, that 0.1, technically if you had surgery or salvage radiation, is still high. We have to watch that, watch them, and maybe that's something that doesn't expand, but I'm still suspicious. Is there benign prostatic tissue? Is there cancerous prostate tissue? So if I see it go up, doing it too early, sometimes they'll give you kind of a false negative that there maybe is something, but it's so small, that lymph node is that under 5 millimeters that we're not going to see it. So for after surgery, my threshold is at least 0.4. If it's not
Got
there
it.
yet, I'll kind of counsel and say, hey, let's keep a close eye, but you may lose it. Insurance may only approve a couple of these scans over the course, and I've heard others say that you can get 3. And so if you had one now and it's negative before I thought I was going to see something, it may use up your use, and then we get another one later, and then you start, if you had metastatic cancer and needed to follow it, you may only have one left. So that's going to be part of the regulation of how much can we do this scan, and there's, a lot of considerations, not just how helpful it is, but cost consideration and what's going to be allowed.
So biochemical recurrence in simple terms for other people usually just means PSA recurrence.
Yeah, so from surgery, if that PSA goes over 0.2, it's a PSA recurrence. It's not a guarantee that there's cancer, but most of the time if it has trended up and it's going up, that's what we're worried about or suspecting. After radiation, a PSA recurrence or biochemical recurrence would be 2 points above wherever your lowest was from treatment, which is often not undetectable, but at a good basal low level. And when it gets to that 2 above, then I think it is helpful, because with radiation, you have a little bit more flexibility that I don't think you need to wait for a certain value, but you should have that at least. There's some that may use it earlier. They say, hey, it's going up, it's not quite there yet, but I think I want to get the scan, and I think that's reasonable. But I would say when it's actually 2 points above where your lowest was, that's a good time to use it.
Since we're on radiation, and I know it's trickier looking at the PSA after radiation, after surgery, it's, for lack of a better word, easier, right? So 2 things, you have to factor in hormone therapy, is the man still on hormone therapy? But second, how do you tell if, and do you still talk about this, if it's PSA bump or bounce, or if it's PSA recurrence, which is cancer? How do you, as a urologist, tell the difference?
Yeah, so we'll sometimes see men early on. It's really the time frame.
Okay.
So if it's early on, you've had a treatment, we had good staging scans, your PSA was, within a reasonable level, under 20 probably, then I think we believe it that, hey, if there's a little bit of a fluctuation, we give it time, watch it, and see the doubling time. There is the risk that, we give it 6 to 12 months, we check it, and it's not going down, that you may say, hey, let's do the scan sooner. But it's within that time frame, and usually about 18 months is the thought, that if it's happening early. If it's been 3-4 years, then it's not really a bounce or bump. It's going to be more of a recurrence concern.
It's got to be hard for a patient sometimes to wait that long.
Yeah, it's
right?
hard to wait
Yeah.
that long. And sometimes you're on hormonal treatments for more advanced, or not advanced, but higher risk prostate cancers for a long time. It could be 6 months, a year, 2 years. And so during that time, your PSA may be really low. And I think some patients will say, well, my PSA went up a little bit afterwards, but it may be that the hormonal treatment, the keeping your testosterone down, was doing that. Coming off of it doesn't mean that if it went up a little bit that it's a recurrence. You had radiation, it's been a couple years, that's okay as long as it stays stable. But you really have to trend it out. Unfortunately, that does take a while.
So it's more complicated after radiation, but, so asking your doctor better questions might be helpful.
Yeah, and knowing that if they're waiting, it's not because, they don't want to do anything about it. It's that there could be this bounce. There could be something that they're reassuring you that is not dangerous right now. But we need to figure it out before we put you back on hormone treatments or do another intervention that's not going to potentially help. We want to make sure that the treatment's going to help you before we do it.
One last comment, thinking about patients listening, if you don't mind. It could be helpful to ask both your urologist and your radiation oncologist this question about the PSA bump versus PSA recurrence after radiation. Could be helpful.
Yeah, no, I think so for sure. And I think what we have sometimes is our radiation oncology colleagues, they're more of the captain of the ships, and they're more involved, understand more of their treatment, what they're doing. But the question is afterwards, well, how do we know, is it distant, is it outside the prostate? A biopsy sometimes can still help, even if you've had increasing PSA with post-radiation. And so the urologist input then to say, are you someone where that's going to help us? Or should we do a PSMA PET scan? Are we looking more for the lymph nodes and bone? Because if it's still recurrent in the prostate, there's other things you can do. It's not just hormone treatments nowadays. There's other options that we could consider, even though that systemic treatment will still be the standard of care, that I think are worth discussing with both.
Thank you so much. Yeah. Any other questions? I think we're good. Thank you so much. Thank you, Dr.
Appreciate it. Okay, death by PowerPoint. This is the last one before before our little soiree here, so just bear with us. I'll be very, very fast. A couple of things. What was I supposed to mention admin-wise? Hold on. What was that? Party at 3:30, yeah, or 3:45 actually, but, there will be an evaluation sent to everybody that's online or that registered for Patient Education Day. One of the things out of that survey is we try to use it every year to make the content a little bit better and a little bit more applicable to patients and to help them learn about these different disease states. You can see we also use those surveys to help entice some of the world's best physicians to come and talk to us about these very technical topics. And it's critical that we get those surveys back, and so we really appreciate your support in those things. What I wanted to end with is, so my organization, or the organization I started, was Veterans Prostate Cancer Awareness. I was diagnosed in 2015 at the Phoenix VA during all of that bad press that was going on. I will tell you that from that point in time until today, the VA has done, with the leadership and the assistance of the doctors, really, and the whole staff of the VA, have finally been given the resources. And I tell people, we tell them every day, if you've got prostate cancer, it is the best place to go on the planet. If you qualify, and I don't know how many of you know vets or you are vets, we highly encourage you to go get your care at the VA. It's not like it used to be. There's my oncologists and nuclear medicine physicians. This is one of the disclosures I should have said. He is my nuclear medicine physician here. They don't have to worry about insurance. They don't have to worry about this cost of medications. They don't have to worry about the oversight that they do on the other side of the street when he's at UCLA. And so they can actually practice medicine, which is what they were taught to do. And so in conjunction with industry and with the military and with the resources that are provided, you do get a marked increase in care. And we can tell you that there's every year the VA does a satisfaction survey, and it comes out that right now, I think last year's was 96% of the guys that are seen in the VA are more than happy and do not want to leave the VA. So it's changed, and that from 2014, that was probably about 70%. So there's a big change. So if you know vets and they're not getting their care in there, they all probably qualify. Encourage them to go. It's very easy, or go to our website and we'll help them sign up. When I was diagnosed, I found out that there was no educational material, or if there was material, it was not standardized. And a lot of this was out of the U.S. Preventive Services Task Force guidelines that had indicated no screening for prostate cancer. And so a group of us got together and decided, somewhere along the line we need to start educating vets, and we need to start finding materials or raising awareness around this disease. Because in the VA right now, today, there was a study that was completed by my old urologist and some of his data people, but there's about 500,000 vets living with prostate cancer in the entire population being treated today. There's about 16,000 current metastatic cases, and we're seeing about 15,000 new cases every year. One of the alarming things, and there's a big debate over whether we're doing a better job of screening or we just have a higher exposure, and I think it's a higher exposure rate and we have a higher incidence rate. But 14% of those that are first diagnosis are metastatic on that first diagnosis. So that's a big deal, and that makes the journey a lot harder, obviously, as we all know, and it's a lot more costly as well. We try to tell people that it's a silent disease. Most of the symptoms go unnoticed. So those things like erectile dysfunction and your incontinence as you get older, those are not normal. You need to go see your doctor about that. Here's a general trend in the United States. The numbers are going up. They're not going down for prostate cancer. Number 2 cause of death in the U.S. And here's something that's kind of new. One of our campaigns last year was Make Blue the New Pink. It's not to take anything away from breast cancer, but breast cancer on average has about $900 million in research applied towards it. Prostate cancer has about $200 to $300 million put against it. We would love to see equity in research funding and research dollars. So we fight on Capitol Hill for that, to try to increase those dollars available to these researchers so that they can do better and they can find treatments or employ these treatments earlier, or look at how we can change this trend line. But this is the year 2023 where the number of diagnoses of prostate cancer will surpass breast cancer in the United States. So it's something to think about, and again, it's just raising awareness and having those men in your life go to the doctor. So it's a big problem in the VA. So these are just some quick numbers on this slide. So there's 19 million vets in the country, a little bit more than that. About 9 million registered in the VA. It's really about 6.5 million that are actively receiving treatment. With that number, about 500,000 have prostate cancer, the 16,000 metastatic, and 15,000 new ones every year. Well, UCLA and a couple of other institutions got together a few years ago and determined that for metastatic patients only, it's about a $200,000 price tag per year to take care of that person, and that's all in. That's medications, scans, outside care, overhead costs, Band-Aids, whatever you're going to put on there, right? So quick math there, 16,000 times 200,000 comes up to about $3.2 billion that we're spending on one disease state and only the metastatic patients in the organization. So you can see if we can intercede with this trend and we can change that, a lot of those dollars can go towards other research, can go to other care, to making the system just a lot better. This is a really bad slide, right? But we'd pushed hard for 2 years, and it's available on our website, bpca.vet. We pushed on the Department of Defense extremely hard. We knew that we had anecdotal evidence or feelings that veteran aviators, military aviators, had a much higher incidence rate of this cancer and other cancers. And there was a lot of sort of anecdotal studies and guys around the bar in the ready room and that sort of thing talking about it. And so we pushed on the Department of Defense. We finally got this through, and the Defense Health Agency actually did this study. It came out in January, was published. It looked at all cancers across the space. So this is very applicable to SNMMI because these are studies, these are numbers that are looking at a very specific cohort of people, right, and doing a very specific job. And this is really all about epigenetics and exposure to toxic issues, whether it be radiation sources, chemical sources, jet exhaust. We know that there's also suspicion of high levels of adrenaline tend to break things down in your body, that sort of stuff. But the study came out, and we really pushed on the organizers of this to do a decent study, like a really large cohort. So they came back with 900,000 people, okay? So 156,000 air crew and about 737,000 mechanics and ground crew. And you can see the statistics. One of the biggest issues that jump out, the median age for incidents was 41 years of age, okay? And then for mortality was about 48 years. We're trying to talk to NCCN, to AUA, to ASCO, to all of the people that touch on guidelines. And I think two of them have already agreed they're going to make veterans placed into the high-risk category specifically for prostate cancer. Because you can see there's a 16% higher rate of prostate cancer amongst us. Melanoma was 87% higher incidence rate as compared to SEER data. So there's some big deals going on here. Thyroid cancer was extremely high, 39%. Higher rate of thyroid cancer amongst aviators. And so something's got to be done. And that's what our job is to really push this. We're talking to Congress about how do we direct the next phase of funding to figure out what causal factors are, whether it's chemical or radiological induced, or how do we get through that whole thing. Luckily, maybe this says it's a good thing for our military and our veterans that our mortality was much less because we're typically in a little bit better shape than the general population. So that's a good thing. But the bottom line is the study was underreported because they didn't look at VA data and they didn't look at the general population data. This was just Department of Defense data. So there's a phase 2 of this. It's already been approved and it's ongoing right now. But the bottom line is that, yes, we do have a higher incidence of cancer compared to individuals in the population. So that's about it. And I will say that from a safety perspective, people always ask, well, what about these scans that we all go through in the PSMAs and now Pluvicto and his other theranostics? So in my case, I was lucky enough to meet Dr. Barangi on my first recurrence. And they've arranged, I don't know if they used me as a guinea pig of one or whatever, a study, of off-label study, but I have had 5 PSMAs. So I've had 5 imagings done of me. I have more pictures inside of me than outside. And I guess I'm still okay. We'll find out. But no, I'm all right. And I'm at 30 months now of my PSA is below 0.01, or it was 0.0, or something like that. So yeah, so that's at about 30 months. So I'm okay right now. Still watching, obviously, but again, I will say too that every time they did an image, except for the last one, my care had changed almost 180 degrees. What we thought, what the oncologists had thought they were going to do, and the radiation oncologists thought that they would find something new or would have to make a change or it would be completely different. So this technology does make a difference, and highly encourage everybody to promote it, to understand it, and to, when it's applicable, you know, we try to promote that if you have prostate cancer or if you've been diagnosed, that you go get a PSMA scan to find out what the status is. So with that, I say take a break, and we'll meet everybody back, unless you've got any questions. Meet everybody back here at 3:45. Yes? What's that? We're going to be out on the terrace, outside, so hopefully the flags are flying and we can all meet outside and network and have a nice evening and afternoon. So with that, thank you so much for a great Patient Education Day.